In the American parlance, I'm going to switch gears slightly because I guess this is something that, once I find how to do this, just something I've thought about since last year when, trying to share the screen there. Here we go. When we had an interaction with one of the members of QCAT, for those that were here last year may remember that, and there's been a few sort of research projects at the hospital, Royal Brisbane Hospital, that involve QCAT, of course, people with capacity. And it did make me think that, you know, from time to time, as ethics committees, we possibly just go down the same track of reviewing things in the way we have always done, use national statement, everything's more than low risk. And maybe we have to look at things a bit differently. And what I wanted to talk about was clinical trials and becoming clinical care. And I don't have all the answers, and I don't actually expect everyone to agree with this, but I think it's important to discuss the question in this forum because, you know, how else do we change? We've sort of talked yesterday about the national statement and the wonderful guidance, as Lewis puts it. But, you know, we have a responsibility as ethics committees to contextualize and recognize that there are more than one way to skin cats as long as patients are protected. Now, I also want to say that it would be a brave HREC that abrogated responsibility for thoroughly looking at clinical trials. So let me take you where I'm going to go, and hopefully you will either agree or disagree, but it will stimulate some thinking. So just what I want to do is consider whether some clinical trials are actually no more than clinical care or quality improvement activities. And then principally do that on the basis of the associated risks and determine whether or not we give them the appropriate oversight or more oversight than we actually should. What I've got here, I just put this together this morning, is really just trying to contextualize the sort of risk associated with the clinical trials. At one end, you have quality assurance, quality improvement. At the other end, at the highest risk, you have phase 1A, phase 1B. In the middle, we may or may not agree. Phase 3, I think, is pretty much bog standard. By the time it gets to phase 3, the risks are really done to death. Ultimately, then it's about the justice to the participants and respect in the sense of whether or not they actually understand the information they're being provided. But down at the bottom, I've actually included Ian Freckleton's human challenge trials there because clearly these can be up at the high end of the scale. And then further on, we have the N of 1 trials, the comparative effectiveness trials that Lewis mentioned, and the RRCTCs, which are the registry randomized control clinical trials. And underneath that, clinical research, which can represent a whole spectrum of things from very low risk to probably a lot more. So I really want to just talk briefly about N of 1 trials, comparative effectiveness, and maybe some clinical research examples, but also some registry randomized clinical trials, because I think it's great to contextualize these. And, you know, we tend to think of clinical trials as a drug trial or device trial where it hasn't been tested. It's a cancer drug, 30-page information and consent forms, pretty high risk, vulnerable populations. We don't necessarily always get these other ones to deal with. And a lot of that can be because many of our institutions or hospitals deal with sponsored trials, which are at the top end of the scale. Now, these are the key papers I have based this on. National Health and Medical Research Council's Ethical Considerations and Quality Assurance, strongly based on the comparative effectiveness trials paper by Tanya Simons and Nick Zepps, who were essentially talking about comparative effectiveness as low-risk studies. And on the right, there are a couple of papers talking about individualized therapy or N of 1 trials, which I'll get onto. Now, I don't want to dwell too much on definitions, but let's just say quality assurance is synonymous with peer review, quality improvement, and quality activities, and used interchangeably. Now, we're quite lucky in Queensland because our legislation essentially tells us that quality assurance, to some extent, is the planning, monitoring, managing, or evaluating of the health system. So managing the health system could be a broad church. Many of the things that go on, I think, in clinical care can really be described as perhaps clinical care or quality assurance activities. Do they always require ethics approval? Well, clearly, if they're not research, then it's outside the remit of an ethics committee. However, they may have, and generally do have, ethical implications, which is where certainly at the Royal Brisbane here, I regularly look at quality assurance activities to determine whether or not A, they're research, and B, whether or not they require some further oversight. And one of the key, I guess, differentiators that should always be looked at in terms of studies is whether or not there is clinical equipoise. That is the assumption that there's not one better intervention. So in the case of comparative effectiveness studies, you're testing your paracetamol versus Panadol, you don't know which is best. There is clear equipoise there. And obviously for studies to go ahead in the clinical context, and even the research context, there should be clinical equipoise. But I think sometimes, I guess we can not over-egg the pudding as such, but maybe even underplay the equipoise and maybe confuse that with what it actually is or isn't research. Don't want to go into the definition of clinical trials, but when we talk about research, I don't know how people have if people have a definition for research. I pulled this off the University of Queensland website, and to me, it doesn't really convey what I understand of research. And if I think of that as hypothesis-based and with a research question, and using a statistical power to answer that research question using research methodology, that to me gives me a better conceptualization of what I consider to be research. Now, the national statement says that one of the triggers for ethical review is the testing of non-standard protocols or equipment. And this can mean innovative protocols. So, initially that might say that anything that tests something that's non-standard, be that an N of 1 trial or a registry randomized controlled trial or a comparative effectiveness trial, requires ethical review. No argument there. The question is really about the level of ethical review, and I think that's more what I want to deal with. So let me just briefly start with registry randomized controlled trials, because I thought this would be more complete if I actually involved them. And this is where you have a prospective registry where you can use that to perform treatment and work backwards from the fact you've actually collected people within the registry. So eligible patients can be recruited directly from the registry. Their history and the usual data is already recorded, but then you can go backwards and say, okay, well, we can actually use different treatments here to see which one is best. And one of them might be standard care. One of them might be one where it may or may not be standard care totally, or it may be used in a different indication. And as it says, you may be also able to incorporate randomization into that registry. They're not things we necessarily deal with too often, but excuse me, but they do allow the identification of patients due to the availability of this information. And you'll see that this TASTE trial, which is the tenecteplase versus acteplase in stroke thromboembolism, cost 10% of the cost of a phase 2 trial. So Lewis mentioned return on investment at the front end, then not having to invest a lot in the first instance and then reaping that benefit clearly is a great value proposition. But what does that mean from a risk perspective? So in this case, alteplase was the standard care for stroke thrombolysis, and this TASTE trial is an ongoing phase 2 trial to test tenecteplase versus alteplase. It's used more than 7,000 participants. And it's used a stroke registry to do this, a registry where myocardial infarctions are measured and stroke as well. Now, this is similar also to a Swedish registry called Sweetheart, but the Swedish registry, of course, has a randomization module. And in actual Sweden, in Sweden, they tend to be a bit more advanced than Australia because people go into clinics with the knowledge that this might occur. So we haven't quite got that far in Australia. But the point is that they did a registry trial. It was a standard care versus a test. And the question really is, what are the ethical issues? And in some of these registry trials, I think there's the literature review, there's 17 trials of which about 11 or 12 haven't received any ethics review at all, principally because they didn't need it, because they weren't necessarily testing one drug versus another. But in this case, clearly they are. So ethics approval required. But if there's already consent for inclusion and there's genuine equipoise, what level of review should be required? Should it be based on the fact that you have one test is standard care, the other is used, and the risks are known for another indication? Does randomization itself cause it to require to be considered as research? So I would suggest in this case, because you're actually having a standard care versus non-standard care, we would agree that it should certainly be reviewed by an ethics committee. But once again, the question is, at what level is that risk? And should that risk or the level of ethics review be related to the risk profile of the drug compared to standard care, if those risks are known? Because frequently I think we tend to over-egg the pudding and just put everything in the same high review basket. And maybe that's not appropriate. So just keep that in the back of your mind. Just wanted to move on to N of 1 trials. Now, N of 1 trials can be used as standard therapy. One of the questions really is where N of 1 trials are clinical trials at all, or whether they're just a form of clinical care. There's different types of them. Some of them involve multiple crossover events, and some of them involve taking away the treatment to see what effect the treatment is having. And for multiple crossover events, for example, where you want to wash something out, it may be an appropriate design if it's a stable condition, it's fast acting, and you can wash out quickly. But the point is you can't generalize from one patient to another. So really, is this research, or really is it just innovative clinical care where it's a clinical question as opposed to a research question? And one way you think about it is this as a sort of case study. If I get a case study, I go, yeah, okay, well, this is research, it's a clinical question. Yes, there may be ethical issues here. Here's my view of it, and it doesn't require ethical oversight. However, there's a view when you have a number of case studies that these comprise research. I'm not sure why the dogma is such, but that's a view. To give you an example of why I don't think all N of 1 trials or some N of 1 trials are just clinical care. And this example here looked at the use of a dopamine agonist following acute brain injury. And amantadine was known to have a role in restoring consciousness, but its role in later recovery wasn't known. So if you look on the left, there's something like 37 vertical bars there, which represent functions that they look to the effect of after withdrawing amantadine and then restoring it. The graph on the right shows you that when they were on a maintenance dose of amantadine and then they ceased treatment, those functions decreased. But 16 days after restarting treatment, those functions were regained. So 34 out of 37 functions were regained using amantadine in 6 years after someone had had acute brain injury. So this was a single case event and demonstrated an improvement in function 6 years post-acute brain injury. But realistically, this wasn't a research question. This was just a clinical question. So this itself wouldn't necessarily qualify as research. Then if I move on to this one, this is a multiple case series to look at the effect of statins on myalgia. And the way I read it, that people have a reaction to statins, which gives them myalgia. So clearly the issue here was they wanted, it can be difficult to distinguish from other conditions, and they may have to lead to statin discontinuation. So don't worry about the fact that graphs are so small. The fact is here, there are 8 different individuals, and they compare the effect of statin rechallenge versus a placebo in 8 patients. So 3 double-blind crossover events separated by a 3-week washout period. And they measured the visual analog scale of pain scores for myalgia. The bottom line was there was no statistical difference between the statin and the placebo in any of the scores. But the point, and therefore it still wasn't generalizable, even though they'd actually used 8 individuals. You can obviously accumulate a lot of knowledge through these 8 individuals, but these are 8 individual events. I guess the thing is, because this was non-standard care and you're using placebo, then we would automatically think this actually requires ethics oversight. It's research, and I don't argue with that. And once again, I think the issue is the level of research required. Compare and contrast that in another N of 1 trial, when I believe that innovative care does become research. And in this instance, using a treatment with a rare disorder with an antisense oligo, which wasn't FDA approved, potentially high risk, clearly needs ethics oversight. And realistically, you consider this to be a phase 1 trial. So hopefully you can see from those 3 examples of N of 1 trials that in actual fact, these can probably lead to different considerations about risk and ethics oversight. In the first case, you may not need ethics oversight at all because it's clinical care. In the other 2, because it's research, you do need ethics oversight, but once again, the question is what level. And so just in thinking about this, I thought it's useful to put together a table giving some idea about ethical considerations. And I don't want to go through the table, but for example, you can be asking a clinical question or a research question. But if in asking that research question, compared to standard care, the level of risk is no more than inconvenience or no more than discomfort, does that mean we shouldn't really be reviewing it in the same way as we always should? Well, clearly in the anti-sense bit, the bottom row, then research, high risk, has to be reviewed by full ethics committee. Now, I wanted to get onto comparative effectiveness trials, and Lewis mentioned that briefly because that's what happens largely in the Northern Territory. And these are the most effective way to resolve treatment uncertainties and should and are embedded into clinical care for the reason you can read there. And I've taken a lot of this from Tanya and Nick's ACTA paper, where they propose that there should be lower risk ethics review for comparative effectiveness trials. To give you an example, if you have 5% extracorporeal membrane oxygenation versus 10%, both of which are considered to be standard care, then clearly there is equipoise if you're trying to determine which one of those is the best care. Now, yes, patients can be unconscious, and yes, the national statement talks about section 4.4 highly dependent on medical care, but realistically, is this a research question rather than just using the data that comes out of the clinical treatment to determine the effect of it? And what I want to take from here is this involvement of QCAT. And as I said, a lot of this talk was stimulated by QCAT last year. And in Queensland, we have the Guardianship Act, and section 74 of the Guardianship Act, amongst other things, defines what clinical research is. And under number 2 there, you'll see a comparative assessment of healthcare already proven to be beneficial is not medical research. And what that tells me with legal hat on is that's not considered high risk. Yes, an ethics committee has to look at it before a QCAT might give approval. But when they say healthcare already proven to be beneficial is not medical research, doesn't that actually tell us that we should be treating this differently? That it's a clinical question, that the clinical issues are being considered, and we as ethics committees don't necessarily have to consider some of those merit and integrity issues that we otherwise would. So just a thought, and please don't throw stones at me for heresy. I just wanted to compare and contrast that just with an example of clinical research that happened at Royal here last year, where patients were already being tested for myocardial infarction and a level of troponin in the blood. And this study was to use another commercial test to determine the accuracy. So ideally, patients could be unconscious or not have capacity. They had to get QCAT approval because that's what you have to do if you want to enroll people. You have to go to the substitute decision maker. But all it did was involve an extra 5 mils of blood at the same time as other blood was being drawn. And this is not a high risk exercise. I hope we would all agree with that. Still went through the full pathway. It's definitely research, but the ethical issues are actually very minimal compared to what's happening to these individuals already. And the consent, was really to use the data. And admittedly, in some cases, people wouldn't be able to give consent at the time, but clearly in order to receive this treatment, the accommodation that was come to was that once they regain consciousness, they would be consented for the use of their data. If they refuse, then we wouldn't have used the data. I say we, the researchers. So a clinical research example where that is probably the lower end of the clinical research scale. Undoubtedly, there are things that are at the higher end. But if we put everything in the same bucket, I think we're doing a disservice to ourselves and to researchers as well. I just put this in here, this example of a full-on RCT, because this is what we understand as a drug trial. A vulnerable population, unknown effect, comparing monotherapy versus combination therapy, not approved by the TGA. Lots of red flags there. None of us would disagree that this should be more than low-risk research, definitely high-risk research. Okay, so that's fine. But what you can see is we actually have a hierarchy of really how we can treat research. But interestingly, what the national statement in section 3.1.6 says, as you can see there, risks should be evaluated in the context of risks of that treatment that would otherwise be provided as part of usual care. But doesn't that then mean that realistically, if we're doing, say, comparative effectiveness research, we ask ourselves, what are the risks over and above usual care? And realistically, if there are none, then we should not be looking at this as more than a low-risk intervention. Now, I know we tend to not think like that, but again, I think this is important just to articulate the fact that we don't want to stop clinical care. And I think the whole point of this is if we take too long to do things, we stop clinical care. But I do take Lewis's point about governance. We still have to go through a governance process. But are we duplicating what already exists? One, because legislation already says it's not medical research, it's clinical care. And secondly, because if we look at the risks relative to the standard care anyway, those risks are actually low. So once again, I think it's useful to make a decision-making matrix, and this is just an example one, by the way, to look at how certain treatments, be they comparative effectiveness trials, clinical research, or a full RCT, can be ascribed to a certain level of ethics review based on additional risks and QCAD involvement, for example. So if one is to say, well, okay, we can actually have lower risk review, what does that look like? And I just put these thoughts down today. I haven't actually formed them. It'd be great to get some views as to how this could work. But if this is really a clinical care exercise, then the merit and integrity are already established. I don't necessarily think justice is established because we have to take human rights, vulnerabilities, and things into account. At least not in all cases. The benefit, I think, is clear because you're using two treatments known to be beneficial, at least in the case of comparative effectiveness trials. So the benefit is clear. Respect is always an issue because one has to put the information in a form that can be understood. And maybe that's the role mostly of the ethics committee. So these other things, consent and data usage, are things we would, you'd imagine consent taking place in the first place. Clearly, when someone is vulnerable or doesn't have capacity, then that's a different issue. But maybe one way is to, rather than having a low-risk committee, you could have a, subcommittee of the HREC, which then ratifies it rather than going through the whole meeting process. Just a thought at this stage, not fully formed, but certainly worth considering because I think as ethics committees, we shouldn't necessarily be putting everything in the same basket. And I think that's possibly what some may do. And, it would be a brave ethics committee that went against that that way of thinking at the moment without this being more fully formed. But I do support Nick Zepps and Tanya Simmons. I think there is a reason for us to think about how we do our ethics review of all of these kinds of clinical trials. So as I said, are we stifling clinical care by thinking about risks in a certain way? And I do like a purposive approach. I go, what is our purpose? What is the purpose of an ethics committee? It's not to prosecute the same old agenda. It is to evolve in the same way as research evolves. The national statement gives us great guidance, but it doesn't mean we follow it slavishly without some consideration of how we can best serve the population and that is a form of beneficence. So just to close off, then, I do think that putting these types of research and clinical trials on a scale is really useful. I'm not saying it's absolute, but I do think that some of these things are towards the lower end of the scale, and we should be thinking in that context rather than necessarily treading the same old path that we have done in the past. And I think it's incumbent upon all ethics committees to evolve the way we think. Hopefully meetings like this can help us do that, but clearly we probably need some further meetings to actually prosecute these sort of questions and consider them further. So Hudson, I will leave it there, and thank you for allowing me to have a talk at the meeting I organised.
Thank you.